Thanks for the invitation, and nice to see so many familiar faces. And to those who I haven't met before, nice to meet you virtually. And hopefully, at the end, if you have questions, please, be happy to kind of speak to those. We're going to be talking about translational simulation. This is a term that is coined by Vic Brazel several years ago, and one that we've now used and adopted to describe some of the work that we're doing. And I'll talk about that. Just disclosure, I do, as Petal mentioned, I'm a co-founder of Advanced Performance, which is a healthcare design firm that does some of this work. But most of the work I'll be talking about today is in the context of the work that we've been doing at Unity Health. I think most of us, when we think about simulation, and I know many of the folks on the on today are very familiar with what simulation is, and so I won't go through that. But we do know that it's predominantly used in the context of medical education, in the context of training. That's where we adopted it from. We brought it over from aviation. The anesthetists did typically, or that's sort of, they were the originators back in the 90s and early 2000s. And since then, it's really flourished, and it's become now a staple for medical training. But what we've come to realize is that there's additional opportunity here with simulation beyond medical education, beyond training and teaching, that we can actually explore, understand, and improve our systems and our spaces much better. And I'm fond of this quote because I think it emphasizes the importance of understanding the environment. And when I say environment, that could be the system, that the space, the physical environment, the people that work within it. But the environment is the invisible hand that shapes behavior. That's a quote from James Clear, author of Atomic Habits. But it's so key to understand, and it really emphasizes and backstops why translational simulation is so important. If we can design spaces, if we can build systems and create processes that work better, then we can really impact behavior, and we can really then focus differently on how we educate people. This is a Formula One pit crew. They can change the tires of this car in less than 3 seconds. It's an impressive feat. These cars come in at hundreds of miles an hour, stop right on a dime, tires go on, the previous ones get changed off, and then the car is out. And it's impressive because, sure, they train very hard to make sure that this pit stop can happen. But if you didn't design this space optimally, there's no way they could do it. In contrast, this is me and my buddy who he called me because he needed to change his tire a few weeks ago on the side of the road. So he called me, and I came out and helped him. It took us about 45 minutes. And I bet you if you put a Formula One pit crew out there with us, they would have done it faster, but still, it would have taken them longer than the 3 seconds that has been designed in the space. And so if you can design spaces better, you can do better. You can train for as much as you want, but if the system and the space doesn't work for you, then it's never going to be it's never going to be allow you to become elite. I want to tell a story. This is one that, and I think hopefully exemplifies where translational simulation comes from, and why it's important. And then we'll kind of get into sort of how it looks in the future. But this is a project that we did a few years ago at St. Mike's, what we called CPR cares. I'm fond of creating names for all of our projects. So it's CPR, of cardiac arrest, resuscitation, in extraordinary settings. And you can see here, this is a mannequin that is in front of an elevator. And what we realized, or what we were hearing from our teams in the hospital, is that the cardiac arrest, the Code Blue team, was struggling with a few elements of how they deliver care for patients that have cardiac arrests in extraordinary settings, or spaces that are unconventional, meaning not in the room, they're non-patients. Maybe they are a patient, they're walking around the hospital and they have a cardiac arrest, or they're a visitor. And how do they respond to those? How do they get the equipment there? Because these are somewhat extraordinary or unconventional locations of care. And one of the questions was, should we be investing in a particular type of stretcher that would facilitate this type of care in these spaces? One that many of you might be familiar with is from EMS. And you can see here's some images of us running this study or running this project, this one with the new stretcher. And we ran it before without the new stretcher, and then we ran it after with the new stretcher. And so we ran it in 2 different phases over the course of a few months. And what we realized was a few things. One, we were able to identify 11 different design, equipment, and role recommendations that came out of this after we video recorded these simulations. We reviewed them, we categorized them, performed a thematic analysis, and then we're able to deliver this to those who were in charge of the operations of this. So I'm not part of the Code Blue team. I certainly understand how a Code Blue team operates, but we were able to deliver this through our sim program as part of our translational simulation program back to the group that we were working with. What we were able to do as well was we were able to save about 30 hours of personnel hours during this process, which we, probably over that. And what we were able to do was understand whether this stretcher that I showed you here was adequate or something that we should purchase. And the typical way that this occurs is there are meetings and we make a best guess on whether that stretcher is a good idea. Instead, by using translational simulation, we just drop the stretcher into the actual space, see how the team works, give them some training ahead of time, and decide with greater certainty whether this is the right model that we should be purchasing. And in fact, we decided not to. There was overwhelming feedback that this was too complicated. The stretcher just wasn't adequate for what we needed. And as a result, we were able to save about $15,000 on this project. Typically, what would have happened if we had not done this, the stretcher likely would have been purchased because somebody would have felt it was a good idea. And then there would have been some degree of consensus and thought, okay, let's give it a shot. We buy it. There's meetings, multiple procurement processes to get this into the hospital. And then it rolls out. And those decisions often are made lateral to the clinical teams who are actually using the device, or in this case, the stretcher. It gets rolled out. We have a problem. There's M&M rounds. There's then decision that we want to send it back. We're not going to purchase further. And the amount of hours really starts to add up. And so this was a critical and really eye-opening approach to making decisions in a much faster way. We had just several meetings. We ran 2 simulations, and we were able to get to high-quality decisions with substantial certainty, and I think ultimately making the best decision. So this is what we look at as we open the door towards translational simulation. What we're talking about are simulation that is focused on health service priorities and patient outcomes. So not education necessarily. Certainly education can be a byproduct, but typically we're focused on how we deliver care and what does that mean for the patient. I'll often use the analogy in some cases that this is like crash testing a car. So what we will do is we will crash test ideas. We'll crash test systems, processes. Sometimes we have new ideas that we want to test. Sometimes we have existing ones and we don't really understand whether it works or not. All we keep hearing about are incident reports that get sent through the hospital mechanisms. And so what we use, simulation, is a form of crash testing to better understand. This is exactly what automakers use. They crash test the car to understand how it will behave during a crash. They don't wait for it to occur on the road. There's too much liability. And for the longest time, in contrast, healthcare would wait for something bad to happen and then respond. And what we do with translational simulation is we can get ahead of that. And so translational simulation addresses kind of three main areas in my estimation, is that it addresses patient safety, it looks at quality improvement, and then we have benefits there for infrastructure design. And so those are the three main areas that we focus on in our program, and I think are the greatest value. When we start making decisions in healthcare, we often have this Venn diagram where work is imagined. That's what happens around the table, around the boardroom table, when administrators or leadership is making decisions, and it's work as imagined. It's what we hope or think work looks like at the ground level. It's neither good nor bad. It's what people aspire to, maybe how they imagine it, but it's very difficult to imagine the complexity of a system that we work in. And then in contrast, work is done is what happens at the bedside, what happens for the clinicians that are there. And you can see, I believe this representation is fairly accurate. The overlap is often minimal. However, what we do with simulation is we help to bridge those two together, so that by crash testing or simulating an event, we can then we can better understand work as imagined, we can better understand work as done, and hopefully harmonize this so that we don't have such disparity between the two, and rather we can make better decisions going forward. I think it's important to recognize that simulation is only a tool. It's not the answer to everything. One of the downsides to simulation is that it takes resources to run. Now, I would argue in many of these cases, the resources required are often less than the numerous meetings that we would normally undertake if we were going to use a comparative process. Like I talked to you about when you can only imagine the number of meetings to bring in a new stretcher into a hospital. The procurement, the RFPs, all of these things would be onerous for those involved. And those are people hours. And those people, if you were just going to look at it from an economic perspective, those people are worth a dollar amount per hour. And so you can start to think about how this is valuable. But we should recognize that there are, downsides to simulation in addition to the resources. It's hard to run many simulations. So if you're looking for large data sets, I don't think we should turn to simulation for that answer. So what we try and do is couple that. So if we're looking at, how do we perform CPR in the hospital, we would look to the data and then use simulation to better understand or to investigate why patterns occur. This is some data that I've presented before from now about 7 years ago, so it's getting quite old, but it highlights how this tracing is our nurses in our trauma bay. This is our old trauma bay a few years ago, and we did this to understand how people move, and this was a simulation that we ran. So if I showed you the actual video, you would have seen people actually delivering care to this mannequin. And instead, we've removed everything. So all the extraneous, the people moving around, and we've just traced out what their movement is. What this highlights is the amount of movement that some of these nurses had to do to deliver care during this trauma simulation, which replicates very closely to what actually happens in real life. And what this exposes is an opportunity. This tells us, hey, maybe we could rethink about how we design this space so that we're not moving so much all around this space, but rather we could consolidate equipment. Perhaps there's opportunities to streamline a process and to make things a little bit more ergonomic. And this allowed us to then launch into what we've now coined simulation-informed design. And this is a process that is it uses multiple simulation tools in addition to other design elements to get to a better design at the end. And this is one part of translational simulation, the infrastructure design piece. And I'll walk you through sort of how this looks. We'll often start with, we work with the architects to understand what is it that they're designing? They'll often have an initial blueprint. It's rare that there won't be a set of plans before we get involved. But ideally, we can start with a blank slate. But we start to understand, we will even step back and understand the current space. So it's a current state analysis that we do at a high level. So we use tabletop simulation to understand what it's like with a 20,000-foot view. And then as we start to learn and we become a little bit more certain about what the design should be, we can build mock-up spaces and run the simulations in those spaces. And so this is a mock-up of a trauma bay that ultimately is a St. Mike's trauma bay. This was built in an office at St. Mike's several years ago. And they installed the booms, and it was highly authentic. So the dimensions were quite close to what we ended up with. And we were able to, before putting in and moving around HVAC systems and expensive changes, we were able to ensure that the space worked as intended. In fact, we were able to also make some changes and adjust some of the walls, compress and expand on certain areas to ensure that the team could deliver the care that they wanted. In fact, at the beginning, we were actually planning on 3 beds in the trauma bay, and we've actually scaled that down to 2 beds because the space was just inadequate. And based on the tracing diagram I just showed you, we were able to understand the circumference of care was going to be too large to accommodate for 3 beds. And so now we can actually scale up to 3 beds, but we were able to make some substantial changes at working with the architects and the design team to deliver a better and more functional space. And then usually just before launch day, we will run in situ simulations. So simulations in the workspace. This is sort of the crash test of the space. And this is the current trauma bay. But just before it launched. And what we're able to understand is, okay, we can't move walls at this point, but we can certainly make some small changes and ensure that the team has some final input into this space. And what's key throughout this entire process of simulation-informed design is that is driven by the end user, by the clinician. And in fact, we will also involve patients. And you can see here, there's a standardized patient lying on the stretcher here. So we actually got feedback for how it felt for that patient to be in this space. Were there elements that they wanted changed? And more recently, we've started to employ VR simulation. This is some work that we do at Advanced Performance with some of the architects, and we use VR simulation before we even build anything. And so this, there's costs up front, we can save downstream by getting better designs, and that when we start to build shovels into the ground, we're actually saving money and not making mistakes. And here's the old trauma bay, how it started. This is where we started. This is where the tracing diagram I showed you. And then this is how it's going. And this is what we currently have as our trauma bay at St. Mike's. It works very well. The first week, we were successful in an ED thoracotomy with the patient walking out of the hospital about a week later. And I'm confident in this process because I've seen it happen enough times, but that would not have necessarily been possible had we not put in the upfront time to ensure that the space was designed with intention. And it works beautifully for the clinicians who are there every day. I'm fond of saying no patient should ever be the first test case of a new clinical space. And I think that that's something that we as clinicians, as simulationists, should aspire to and push our groups to follow. We would never get into a car that had not been crash tested. We shouldn't allow our patients, our loved ones, to be the first ones in a clinical space. We should be testing that ahead of time to ensure that it works the way we intend. So that's a little bit about simulation-informed design. We also use, as I mentioned, through translational simulation, we use simulation or translational simulation to understand and improve patient safety. This was a study that we did now 6 or 7 years ago as well. And we recreated trauma simulations based on M&M data. So we created scenarios that were coming up. We're currently in our M&M review, and our adverse events database. And we used those to then anchor the simulations that we were running, and we could then understand where there may be some latent safety threats. And we conducted a fairly comprehensive and extensive analysis using video review, and human factors experts were present in the trauma bay doing all of the analysis with us. And we were able to identify 843 latent safety threats over the course of about a year. Now, I do promise, like, we are delivering safe care. It might sound scary that we have 843 safety events, but we were able to then have a framework of identifying these, working through them, and making system-based and design-based changes to improve that. The other piece of translational simulation is quality improvement. And so this is kind of the third piece. And this is a study that we did, I think at the end of 2019, 2020, just as we were moving into COVID. We were looking at how do we improve the time to blood delivery for bleeding trauma patients. And what we were able to do is we ran simulations at the beginning to understand what the current state is. Then working with the team, and again, this was not necessarily with simulation. We did other stuff. We worked with nurses, blood bank. We started to brainstorm ideas. And then as we repackaged a process, we tested it before it went live. And then we looked at what is actually happening with real patients. And what we found was a reduction of time to blood delivery by about 21%. And so we saw several minute decrease in our time to blood delivery. That may not seem like a lot, but for a bleeding patient who's about to bleed to death, every minute or so of delay increases your odds of death by about 5%. So we were able to impact, somewhere between 10 and 15% odds of death and reduce that down. And we've been able to do that even further over time by better understanding the practice using simulation. And so what this all does is it gives us more data-driven design elements. It gives us evidence to make better decisions. And it's this that's really key. And then as we start to move into what do we do next? This is the pitch that we use towards leadership, those that are funding these initiatives, those that are not yet on board. How do we convince them? And I think what we have been missing in simulation for the last 30 years is the return on investment. We just think it works. We've done studies that it works for education. People get smarter by using it. They're better trained. That's all great. But the work that we're doing now in translational simulation is honestly impacts greater, and the pitches land better because we're now talking about money and outcomes. And as much as that may not be something that we typically like to focus on in our healthcare system, it is actually really critical that we address this. And so if we're going to be doing and spending time on using these types of tools, we should make sure that they work as intended and that there is value that we're bringing. And I'm fairly confident there is, but let's talk about how we can start to think about this. And perhaps if you're interested in bringing these types of projects to your institution, these are the ways that we've started to think about the return on investment. Obviously, there's the patient safety elements, and we're now starting to see through the literature, and some of which is the stuff that we've published, improvements in time to CT for stroke patients. And we've done some work with this at our site. There's some nice publications out there to the UK about how they've reduced door to needle time and door to CT time. Time to blood delivery is some of the work we've done. There's some nice data on reducing ICU length of stay because they've been able to better design the central line insertion process in ICUs. It then reduces bloodstream infections. You have less catheter-associated bloodstream infections. You have a shorter time in the ICU. This all benefits patients, and they are using simulation to help this along the way. And then the big ticket item is how do we get patient survival improved? And there's some work that's come out of the US around inpatient cardiac arrest, in-hospital cardiac arrest survival, teams that are regularly undertaking in situ simulation training and evaluation of their process have found associations with improved survival. There's no randomized trial data yet on this, but it does seem like there's a signal towards it being beneficial. And then, obviously we all love great patient stories, patient outcomes, but when we're trying to pitch how we can get this in an institution, we want to see savings. So what we've found is capital cost savings of up to 18%. There's some really nice literature out of Alberta that demonstrates renovation savings on future renovation costs of up to 500%. So for every dollar you put into your simulation program, you get about $5 back on savings of future renovation costs when you're using it to design new spaces, which is really impressive. And then, broadly, we're starting to see, we can see reduction in safety threats. We can improve design time, and we can save on costs. And then this is the piece that hasn't been well studied, but I'm confident based on our experience that this is real. I've been this person at a meeting, fast asleep, and maybe, the irony today is that I'm talking about simulation instead of running a simulation, and we're instead having a meeting, and some of you may be asleep. But when you're trying to make decisions and you're trying to do so around a table, that is one strategy, but there is no better way than to truly engage people, is to get them into the space, running through a tabletop simulation, running through a physical simulation. The engagement level goes up because they suddenly feel that they're part of the process. They can share, that these are end users that are sharing their own experiences, rather than the less efficient strategy of meetings. And meetings are important and they're useful and they're necessary, but there are better ways and alternative ways with the right process to get to where we want to go. And so looking towards the future, what does that look like? What does translational simulation look like as we look out, as we emerge out of a fairly tough time through healthcare? And to be honest, it doesn't seem like it's getting any easier. So how can we take this and move forward? And I think that the future looks at and lies with a seamless integration of simulation, and specifically translational simulation, within a healthcare structure. If we're talking about a hospital, within a hospital structure, looking at integration of simulation within the QI pathway. And so you can imagine that the ideal is not only are we feeding in actual adverse events into a QI mechanism, but we're actually feeding in simulated scenarios. We don't need to wait for a bad outcome, cardiac arrest, to occur. We can create that, better understand that using simulation, feed that data into a hospital or an institution's quality assurance pathway or quality improvement pathway. And so we don't, rare events, there is no such thing as rare events using simulation, because we can create that every day of the week if we wish. We can integrate translational simulation into the design process of healthcare infrastructure. And we can start working with architects from day one. We can start reimagining how we use the user groups that they are fond of using. We can actually bring them in and help them better understand what it is we do, align the work as imagined and work as done in a tighter way. And then throughout the process, like I described in simulation informed design, we can integrate seamlessly translational simulation into the design of new healthcare infrastructure. And we certainly can see that across the province. There's a wealth of resources that are now being dedicated to the design of new spaces. And so simulation is going to be absolutely key to make sure those spaces work as we all want them to. And it's this integration within the hospital network, I believe, will feed forward and allow us to make better decisions faster with greater certainty, because that's what we are all seeking for. And this benefits our patients. This benefits us. It helps to reduce burnout because we're not so frustrated. We can increase satisfaction of coming to work, because we all are familiar with looking around a space, being frustrated with an EMR that doesn't work for us, or working in a space, a physical environment that we can never find what we need. This weighs on us and chips away at us as clinicians over time. And so if we can do better, we can retain people longer, we can bring satisfaction back to the healthcare that we're trying to deliver. And so we're going to conclude and then hopefully open it up for comments and questions. But translational simulation has moved beyond education. What we're looking at are the healthcare service priorities. We're looking at patient outcomes. And I think I see it in three different domains. We can improve patient safety. We can optimize our processes and our systems through quality improvement, and healthcare infrastructure design can be improved by using some of these tools. And I should mention that it is critical that it's coupled with other mechanisms, other processes. That we will all, we have large data sets that are now available, and we'd want to see how these couple together. We have existing patient data. There are different ways of imagining this, but this is certainly, I think, a key tool towards a better healthcare system. And with that, I'll conclude. I hope that there's some comments, questions, and thanks for being here. Thanks for the invitation, Petal. It's an honor, and it's great to kind of kick off the new year, or the new academic year, with a talk on something that I certainly feel passionate about. And by all means, please send me an email or hit me up on Twitter if you have any particular questions or comments that aren't answered here. And with that, I'll stop sharing.
Thanks so much, Andrew. That was a really impressive and informative presentation. And I think I'm happy that we have a good 22 minutes to open the floor for some discussion and questions, because I see a lot of simulation center presence here, so various sim centers across TASAN, as well as our managers. And I'm sure we'd love to pick your brain on this topic. Tim.
Morning, everyone. Thanks, Andrew. I'm really keen on this won't surprise you, the advocacy end of this, right? And where you talk at the end about getting this embedded into safety and QI processes. And you and I have both been trying to champion this kind of application of simulation for a while. So I'm curious to hear from you, what successes have you had? What kind of language have you been able to use that has convinced hospital leadership to give this a go?
Yeah, it's great question. I mean, I don't know that we've solved it where we are, but we continue to chip away at these ideas. I mean, part of what we do, one thing that we find helpful is to invite those that might be involved in that to the simulation, so they can see what's happening. We video record it. We show them exactly what we expect. We bring them down, we tell them what to expect, and then they can watch it play out. And so by using existing data sets, whether it be M&M rounds or adverse events, we then can replay that. And we do so carefully. We're not, we wouldn't pick a case that was overly traumatic from a psychological perspective, but one that would have themes that then allows us to really understand why things might happen. Or perhaps what we see clinicians sort of overcome something that we thought they would act differently. And then that helps us better understand what's exactly happening at the bedside and the types of decisions people make. And by bringing in those that are involved, healthcare leaders within the hospital to watch, I mean, it really does it makes it live for them, because often those that are involved in the decision-making may not be at the bedside, all the time for these types of things. So we found that by doing, some of the work has to happen, and hopefully some of the work that we've done will be useful to others. But by publishing some of this work, by regularly talking about it, by doing these types of rounds, we can start to show that it does have an impact. And, regularly now I'm invited to give talks to QI people because they see this as valuable. And so some of it, I think, is a inevitable shift in how we understand complexity of a system, right? It's too difficult for us to imagine how complex the system is in our minds, right? We can never imagine all of the different ways that something could play out. And we've been able to find this, by showing it through simulation. I think there's lots of work that can continue to be done. I mean, there are some examples in the US where some colleagues of ours integrate their simulation, right? They feed it right into their QI database. So whatever just like you would have every cardiac arrest, actual cardiac arrest would get fed into the cardiac arrest database. They also feed in their simulated cardiac arrests. And so I think, the future will be that these would be seen as equal. And exactly how that happens, I do think that part of it is relationship building, and there's no better way to build those relationships with QI people than to bring them in and watch them and help them understand. We need to realize that most of us here have a background in education. That's how we came to simulation. So we're slightly separate from those in QI, and so recognizing that they might see things differently. They're more used to the more iterative approach that like a lean methodology might take or something, and this is just a different toolkit that would allow us to get there.
I like that you highlighted the importance of simulation as an educational tool and not a replacement for the expert educator. It's an underutilized tool for sure, and it does require a lot of resources, both financial and otherwise. But there's a question in the chat from Latika Nurula. So what role can translational sim play in addressing issues of equity and accessibility? Examples of what you have seen would be great too. And then Agnes seconded the fact that was what she was thinking of as well.
Yeah, great question. And I think one that we are kind of continuing to answer over the last few years as it's become more evident in healthcare that we haven't done as good of a job, I think. And now that we can start to we understand where we may have some pitfalls. I think part of the analyses that we'll start to do now is, just like we analyze, we'll run a simulation for, and one of the themes we might look at is the equipment or the space. Well, the next theme, the theme that we should also be integrating there is, what are their equity issues and accessibility issues? And even just asking that question. And then in the debriefing, exposing that and bringing that to the forefront is something that we've started to try and integrate into these processes. So bringing it forward as a key theme, I think is where, the starting point for this. And I think I see Lindsay and Nazanin, who have been involved in some of trying to moving this forward within our program, have been, may have some additional comments to what this can do. But practically speaking, using we start to frame debriefing conversations. And I didn't talk about how we debrief these simulations, but we'll actually explicitly call out particular themes. We'll say, okay, let's talk about equipment now. Let's talk about the space. Let's talk about the system. Well, let's talk about, was there any impact from an equity lens that this patient did or did not, receive care in a way that's appropriate, or can we do better? And so by calling that out, then we can start to, better understand. And I think we shouldn't necessarily look for the simulation to give us the answer. But what we might be able to do is it gives us an opportunity to look more closely at what's happening more precisely in how care is delivered in a particular environment. And so I think that these are the types of things that, there's not that much research in this area in simulation. And it's one that I think is probably needs further study. And frankly, if this would be an opportunity to start to explore, how can we use translational simulation to bring out equity and diversity elements I don't mean this as like, how do we teach it? I mean, how do we understand it better? Because what we get to do with translational simulation is understand care and the delivery of healthcare in a particular way.
Thank you, Andrew. And then Stephanie Sleekers in the chat said she was curious to hear more about how specific processes were identified or selected as ripe for improvement. She said you mentioned things like adverse events, M&M rounds, and she was wondering if there were other factors or conversations that helped you determine what you wanted to study and simulate.
It's a great question, and sometimes we'll just run the simulation with kind of an open mind and a blank slate. Sometimes we're tagged already that there was a problem, and then we'll investigate it. But what we try and do is be as agnostic as possible without sort of saying, hey, this is the actual problem. Because we often jump to that too early and we start to seek solutions. And so rather, what we might say is, okay, there was a problem with the end tidal CO2 monitor for the last cardiac arrest. Well, maybe that wasn't the problem, but we'll recreate the event to bring that out and see. But perhaps it was a educational knowledge gap. Perhaps it was there's a a module that doesn't connect properly. That we try and we'll get approached by with a particular problem. But we then try and take a step back and say, okay, we'll just use that as our anchor to explore this more and be open-minded. Because the minute that you just focus in on, and this is I guess a criticism of often QI is they'll get tagged with a particular problem, and then they focus in right on that. And I don't mean to slight those that do QI. I do that as well, but it's a natural tendency. We all sort of focus in. And so what simulation allows us to do is better understand the entire system. And we will then, prioritize we'll often use a framework analysis where we will assign is it likely frequent to happen? Is it high risk? Is it low risk? And we'll start to assign in a hazard matrix kind of way what works, what doesn't. And so I don't think that there's a right way to do these things. I think that we've continued to learn over time how to prioritize and pick, and sometimes we miss stuff, and I think that's okay. I think thinking that you need to be right is a flawed paradigm. So you just pick, you do your best. I mean, you ask people, you ensure that there's a flat hierarchy and explore like, hey, how did that all work in the debriefing or in the analysis phase? And then you kind of go from there, and you can run it again if you don't think you got it right.
Jordan?
Thanks, Petal, and thank you, Andrew. That was really great talk. I just wanted to pick up on something that you mentioned before of, we can't imagine all the ways that things are going to go wrong, right? Because our systems are so complex. And I can't help but ask an education or learning question. But I was wondering your perspective on, do you think that participating, like the clinical teams that participate in these translational sims, have you noticed, or do you think that by this mechanism of participating, are they more prepared for the kind of complexity that they face in their clinical realities? Do they learn something by doing this is what I'm asking.
Right. Yeah, it's a good question. One that I don't have hard data for because we often don't study the educational outcomes. What I do think occurs is, one, we're working with a fairly high set of performing individuals in these cases, right? Whatever the domain is, whether we're using the emergency department, whether we're in surgery, whatever. So these are all pretty highly intelligent people who are very good at their job. But what this does is it gives them a voice that they may not otherwise have, or it gives a more, it opens that opportunity for feedback. And then that you become more engaged in your work over time. So I think that we're getting, 1% marginal gains at minimum by doing this type of stuff. So that people, I don't know, maybe they're getting better at it, maybe they're not. But I do think that if they feel that they are part of the solution, that they have a voice to give feedback, that it's heard, I am willing to bet that they will deliver better care over time consistently because they feel like they're engaged. They're there. People are listening to them. That suddenly when something, when there's a change made, they're like, yeah, that was my idea that we, took from last week's simulation. Hey, I'm going to just, in even subconsciously try harder. They're not actively trying to be better, but they will. That's a positive feedback loop that just makes work more enjoyable. And when people are experiencing joy at work, they're better at their job.
And so Douglas rightly said that sim is a way to create a culture shift. And I think that's very much.
Yeah, I think that's key. What it does is hopefully offers an opportunity to flatten hierarchy in places where we have, an inevitable hierarchy. There's nothing wrong with a hierarchy at all. We need people to be to lead an organization, and we need people to be, what we consider typically like frontline or ground level. And that's normal. That's okay. But what we do need to have is a mechanism for conversations to be had on equal footing. Not all the time. If you're going to war, you need somebody to be the general to lead. And in times of crisis, we don't have to look too far ago. We needed leaders to lead in a way. But at times when we're trying to explore solutions, we want to flatten that hierarchy so that as many different people can give as many different perspectives so that we can then solve, I think, better, right? So many good ideas come from not necessarily our leaders. The best leaders are those who listen best. And then will, certain times they'll make decisions, but they will understand all of the perspectives. And that's what translational simulation brings out.
So I'm saving Lindsay's comment for a bit because I'm going to do a plug of my own. But Jordan just commented, do you ever use translational sim to take the safety 2 lens of also investigating why things go right?
Yeah, absolutely. I think that is probably, one of the flaws of the QI paradigm over the last 30 years in healthcare is, and simulation probably would fall under this as well, because we use simulation to identify things that go wrong, or we investigate things that go wrong. And for those that are not familiar with safety 2, this was an idea from Eric Holdnagel, who's might be a psychologist. I'm not sure his exact role, but he's in Europe. And it's this idea that about 90, if you plot out all of the things that happen in a system, 95% or most go right. It's not like everything is failing unless you're a completely novice organization and everything's going wrong. Most things go okay. In fact, most things succeed, right? But to understand why they succeeded, there's oftentimes we'll develop workarounds on the fly. Why is it that this happened? So if we only address things that went wrong, then we are missing a large piece of the pie of what's gone right and why did it go right? Was it lucky? Do we have consistently, like our nurses or our docs, working around a flawed design and they're just gotten so good at it, which is often, I think, the case? Or is it truly that there's just excellence within the field? But what we want to do is not only just say, okay, we shouldn't do this again. We shouldn't, if something keeps going wrong, okay, we should change that. We want to figure out how we can make things right all of the time, not just 95% of the time. And so this safety 2 approach, for sure, we will run cases where nothing's meant to go wrong. And then we actually just spend the time highlighting, okay, why was it that it went right? But if you ask the question, maybe there is actually, we've run simulations like this where people have just, some of our expert nurses have just like, oh yeah, I saw this was going to be a problem. And I actually knew that it was going to be a problem. I worked around it and we were able to overcome this. But that never would have been flagged in a safety report because nothing actually went wrong. And so there you now have a learning. But if you replace that experienced nurse and put in a novice nurse, then there may have been a different outcome. And so now you can say, all right, let's feed that back into the educational platform and say, all right, one of the areas we need to address is making sure that, whatever that clinician was doing, that they do it all the time in one particular way. So absolutely. Safety 2 really should be coupled with all of your translational simulation work.
So Stephanie Sleekers thanked you. Elizabeth Horsley said, outstanding presentation. And Lindsay Beavers commented, reinforcing and adding to Andrew's comments, we need to explicitly call out issues related to equity and inclusion, but also purposefully engage folks and communities who we know have been harmed in our spaces versus SPs who may or may not have different types of privilege. And I'm going to add to Lindsay's comment by saying, in a timely way, on September 26th at noon, our next SimCity round speaker will be Dr. Jerry Maniet, and his title of his presentation is going to be Exploring the Role of Collaborative Partnerships to Further Health Equity. So I think that there is some alignment there from what came out of this discussion today. Any other, I'm just going to scroll down, any other comments, questions for Andrew? Praise? Always take accolades.
Well, I appreciate everybody joining in the discussion afterwards and the conversation and the insightful comments and questions. So thanks for having me, Petal. I appreciated it. Oh,
we really enjoyed it, and I want to say thank you to everyone. This was one of our record turnouts for our round. So Andrew, you're a star. I think at one point we had 33 attendees, and so I'm thrilled. And Ricardo just added our SimCity newsletter, our email, so that if those of you that are here today would like to continue to be involved in these rounds, please email us and we'll add you to our listserv.
Yeah, it's a great initiative, and thanks for spearheading this, Petal. I think getting the community together periodically and hearing different ideas and new ways of thinking, I think is really great, because there's so much expertise in the city.
As long as you take me and Doug with you to Malaysia, we're good.
I'm looking forward to that invite. Yeah.
Me too. All right. Have a great rest of the day, everyone. And thank you so much for your time.
Thank you.